I have no attention. Hi, everybody who's logging on, I see lots of people jumping on to the webinar for today. Welcome and thanks for joining us. We'll get started in just a little bit. Let's sort of watch the queue fill up first, or the crowd, I guess. See some familiar names, friends. Still see people coming on, so I'll wait just a little bit more and then we'll get started. Just a second here, and then I think we'll get started. Seems like we're pretty stable, folks, so I'm gonna get the webinar started. So hello to everyone. My name is Jeff Smith, and I'm the interim director of the Institute of Cannabis Research hosted at Colorado State University, Pueblo. Welcome to the Cannabis Research webinar series, which is presented by the Institute of Cannabis Research and the Lambert Center for the Study of Medicinal Cannabis and Hemp at Thomas Jefferson University. This webinar series in collaboration with the Lambert Center is one of the many ways that the ICR works to promote the dissemination of cannabis research. For example, please see our website, which you can all find by Googling the words Institute of Cannabis Research. You can navigate to our outreach tab and find the current e-newsletter. You can also navigate to the research tab in our website to view summaries of each of the research projects that the ICR currently funds. We're also happy to report having received a record number of applications for new research funding in the next fiscal year. The ICR needs scientific reviewers to help evaluate the scientific merit of these proposals. So please contact us if you're interested in serving as a reviewer. You can also find information about future monthly webinars. Also on our website, note the link to the Journal of Cannabis Research, which the ICR sponsors. The journal is published by prestigious Springer Nature and is always looking for both high quality scientific article submissions and reviewers. Finally, we're going to be hosting the ICR's 7th annual research conference next August in beautiful Denver, Colorado. We're happy to announce having approved a record number of abstracts this year. Registration is open, so please register for our conference and come learn about the very best current cannabis science. Additional information about the ICR is also available on our website, so please visit us. Before we get started, I'd like to mention some logistical items for the webinar. Today's presentation will be followed by a short question and answer period. To ask a question, please do so using the Q&A feature in the Zoom toolbar. You can enter questions at any time during the presentation, and we will address as many questions as time allows at the end of the hour. Please reserve the chat function in Zoom for technical issues and questions. Both the Q&A and chat functions can be found in the toolbar on your Zoom screen. This is the part of the webinar where I would normally introduce Ruth Charbonneau, who is with the Lambert Center, and she usually introduces the speaker, but I'm going to do it today since Ruth is out. So it's my pleasure to introduce Dr. Tory Spindle, who got his PhD in experimental health psychology from Virginia Commonwealth University. Dr. Spindle utilizes human laboratory studies to characterize the behavioral pharmacology of cannabis and individual cannabis constituents. His research seeks to understand how factors such as the route of administration, formulation, chemical formulation of particular products impact the pharmacokinetic and pharmacodynamic effects of cannabis. Another emphasis of his work is on characterizing cognitive psychomotor and driving impairment associated with cannabis when used alone and in combination with alcohol. Overall, Dr. Spindle's work is to inform policy decision making involving cannabis products, standards and accessibility, dosing guidelines, procedures for detecting cannabis impairment. The overarching goal of his research is to inform policy and regulatory actions for cannabis. So his work could be probably described in a nutshell as cannabis regulatory science. So it's my pleasure to introduce Dr. Tory Spindle, who is coming to us today from his position as Associate Professor at Johns Hopkins School of Medicine, Department of Psychiatry and Behavioral Sciences, Cannabis, and he's going to talk to us about cannabis regulatory science. Hi, Tory.
All right. Thank you, Jeff. That was a great introduction. I appreciate it. And John, I appreciate the invite. I'm really happy to be here and excited to share some data with you guys. Can everyone see that? All right. Sounds good. So as Jeff mentioned, the title of my talk today is using human laboratory studies to advance cannabis regulatory science. So I'm going to kind of talk about various studies I've done over the years in my lab that are all kind of geared towards advancing regulatory science or informing regulation or the eventual regulation of cannabis. So I don't need to tell anyone this here, but I just like to just start off the talk by orienting everyone. So cannabis laws are obviously changing rapidly in the US. Currently, there's 38 states and DC that allow for medicinal cannabis use and 22 states that allow for non-medicinal recreational use. And these numbers seem to be changing every 6 months. And so it's really changing at a rapid pace. But current federal policy is very confusing. So as most of you are probably also well aware, cannabis that contains over 0.3% THC or synthetic cannabinoids are still in the Schedule 1 of the Controlled Substances Act. So this is the most restrictive drug schedule, basically high abuse liability, no recognized therapeutic potential. However, cannabis that has less than 0.3% THC, which is also called hemp, and anything derived from hemp is now considered federally legal via the 2018 Farm Bill. So this has really created this rapid growth of the CBD industry as well as industries for other non-cannabinoid products, and I'll talk more about that in a second. As far as current regulations of cannabis, there really isn't any federal regulatory oversight. So the FDA or any regulatory or federal regulatory body doesn't oversee cannabis regulation. So each state sort of has their own standards and regulatory structure that have legalized cannabis, whether for medicinal or recreational purposes. And just to illustrate how there isn't really a framework in place, the FDA recently released a statement concluding that the existing regulatory framework for foods and supplements is not appropriate for CBD or other cannabinoid-containing products. They haven't really said anything about cannabis, just CBD and other cannabinoid-containing products, but I imagine the same would apply to cannabis as well. So why is regulation of cannabis important? So as many studies have shown, some in our lab and other labs, currently there's such poor regulatory oversight that there's very poor product standards. So it's very common that cannabis products are inaccurately labeled or contain contaminants of some sort. Regulation is also needed to deter misleading or unfounded health claims. So it's kind of the Wild West right now. Companies can kind of make any kind of health claim they want. They can say a product cures cancer, and there's largely no one to really hold them accountable for those kinds of health claims. So regulation can help to deter such misleading health claims. Regulation is also important to mitigate appeal to youth. So you think about edibles or other products that are very much geared to look like candy and other analogous kind of treats. So those kind of practices probably will go away if there's some kind of regulation in place for these products. And it's also important to ensure that products on the market are safe and effective for an intended medical condition. And part of this, in my opinion, is ensuring consistency in dose delivery. And so I'll talk more about what a lot of my research is focused on is trying to understand all the different factors that can influence cannabis effects. And so this understanding is really critical to ensure that dosing is consistent for either a medicinal user or someone using for recreational purposes. So regulatory science is really broadly defined as science that's it's geared towards informing regulation for a drug or whatever substance it is. So cannabis regulatory science is really kind of in its infancy as a field because there isn't really a structure or an overseeing body to inform or to actually enact a lot of these regulations. So a lot of the research is perhaps a little bit ahead of its time, but nonetheless, it's still important to focus on certain key areas for cannabis. So for one, I think I alluded to this already, but we need to understand what product features of cannabis products can influence their effects. So again, this is really critical for understanding and ensuring consistency and accuracy in dose delivery. There's dozens of different kinds of edibles, different vapes, different topical products. So understanding what constituents are important and influence the effects are going to be important in order to inform regulatory action in order to result in some kind of consistency in cannabinoid delivery. Another key area of focus is cannabis impairment and understanding how to detect that at the roadside or workplace. I'll get into this as well, but we know that cannabis, driving under the influence of cannabis rates are increasing, especially in states where they've adopted a recreational cannabis infrastructure. So really understanding how to identify people who are impaired and importantly, differentiating those who are impaired from those who used recently but aren't impaired is really becoming very critical. Also understanding how marketing practices impact cannabis initiation and effects is important, as well as efficacy for different therapeutic conditions and quality control of different cannabis products to again ensure accurate labeling and absence of contaminants. So what I'm going to focus on here mostly today are the first 2 points, which is again understanding the product features of cannabis products that influence their effects, and also understanding how can we go about measuring cannabis impairment and doing so in a reliable fashion. So there's, as I alluded to, there's very extreme variability in cannabis product features. And this is kind of an issue because we have a limited understanding of what features influence cannabis effects, and meaning pharmacodynamic effects or what cannabis actually is doing to a person, or pharmacokinetics or how the drug is being absorbed and metabolized by a person. And this has critical implications for minimizing harm for cannabis users. So reducing the incidence of adverse events, for example. If there's a particular constituent that may increase the chances of an adverse event, it's going to be really important to understand that so that someone can mitigate the chances of that happening. And also for the general public to deter or to mitigate instances of driving under the influence, for example. This also has really critical implications for dosing decisions for medical use. So not considering THC products for a minute, CBD or other medicinal cannabinoid products, it's really critical to understand factors that influence absorption so that we can ensure more accurate dosing and also more consistent dosing. So getting into some of the ways in which cannabis actually does vary. So as many of you probably know, cannabis contains many different compounds. So most people have heard of the 2 primary cannabinoids, THC and CBD, but then obviously there's many different minor cannabinoids as well, CBG, CBN, delta 8 THC, and then there's entirely different classes of compounds as well, including terpenes and flavonoids. And we know even less about these than we do for the other minor cannabinoids. Then obviously it gets more complex than this. So there's many different forms of cannabis and many routes of administration. So people can smoke cannabis, they can vape it, consume it in edibles and many different varieties. There's topical products, there's extracts. So cannabis isn't really one thing, it's more of a very broad product category that then becomes a bunch of other smaller product categories. And then obviously there's many different strains of cannabis or chemovars. Generally, they can be categorized into THC dominant, CBD dominant, or mixed equal ratio of THC to CBD. And there's many claims about what these strains could do, but very little research to support or refute this. And then the most recent development is the introduction of non-THC cannabis products. So you have non-THC cannabinoids like CBD is the most common, but more recently CBG, CBN, other minor cannabinoids have become popular, as well as THC analogs. So delta 8 THC, THCO, delta 10 THC. And so switching gears here now, just giving some intro on measuring cannabis impairment and why that's important. So again, with expanding legalization, the incidence of driving under the influence of cannabis has really been increasing. And so there's really a pressing need to be able to objectively identify people who are impaired from cannabis at the roadside and elsewhere. And again, to be able to differentiate between people who have used recently and aren't necessarily impaired, maybe they used the night before, maybe they're using a high CBD product with some THC, from those who are actually impaired and have used recently and shouldn't be driving. So the way that we can begin to answer some of these questions and address some of these topics is to do systematic controlled studies. And so that's what we do in our lab. We do controlled dosing studies where essentially we bring people in, give them a cannabis product and study what it does. So here is our lab at the Behavioral Pharmacology Research Unit, and our lab is known as the Johns Hopkins Cannabis Science Laboratory. So just an overview of how a cannabis laboratory study would work. So this is a mock researcher and experimenter. So essentially, we bring people in, we give them a cannabis product, and we study what it does under controlled conditions. So during this time, before and after, we can take biological specimens. We can measure blood, oral fluid, and urine cannabinoid concentrations, for example, to really get some insight into the pharmacokinetic profile. And if we want to, we can also have people stay in a nearby inpatient unit to measure pharmacokinetics over several days. We also do several subjective questionnaires. So we ask people, did the drug you took make you feel positive effects, negative effects? This can give us an insight into abuse liability and adverse events of a given product. We also do various cognitive performance testing, assessing things like working memory, psychomotor ability, divided attention, again, all very important for driving and functioning in the workplace. And then we can do basic vital signs and get a better idea of the overall safety profile of a given product. And then some of our impairment-specific testing, we recently acquired a driving simulator, so we've been integrating that in some studies, and we do field sobriety testing to understand if any of the current tests being used by law enforcement are effective for cannabis and could be used at the roadside. So first, I'm going to get into the first area of research that I spoke about, which is trying to understand, again, what factors influence cannabis effects. So I kind of categorize this into three different areas. So first is route of administration. Second is non-THC constituents and how they have, whether they have effects on their own or interact synergistically with THC. And then I'll get into some other product features that we found are also influential. So some of our earliest studies in our lab were really just trying to understand basic differences across routes of administration. So most common routes of administration currently are smoking, vaporizing, and oral ingestion or cannabis edibles. In all these earlier studies, we would actually make cannabis brownies in our pharmacy, and we would either use the Volcano vaporizer or more recently the Mighty Medic. And then participants would smoke cannabis through a pipe. So getting into some data here. So this is subjective ratings for do you feel a drug effect? So just not specifying good or bad, just do you feel a drug effect right now at this particular moment on a scale of 0 to 100. So you see here on the y-axis, 0 to 100 ratings. And then here on the x-axis, you see the time points at which we asked this question. And so the left here, you're seeing a 10 milligram THC dose across the three different routes of administration. The right here, you see 25 milligrams THC across the same three routes. So a couple of things that are important to take away from this is that if you look at the same dose, within the same dose, 10 milligrams or 25 milligrams, you see that vaporized cannabis produces more pronounced subjective drug effects compared to smoked cannabis. So they're both inhaling the same exact dose, it's just they feel stronger effects from one versus the other. Looking at the oral dosing condition, we see that participants are overall experiencing a similar magnitude of effect from oral ingestion as they are to smoking. It's just that it happens much later. So we see peak subjective effects are about 2 to 3 hours after oral ingestion, whereas they're more or less immediate after smoking or vaporizing. So very key differences across route of administration, despite using the same exact dose. We also see the same thing in cognitive performance testing. So these graphs are oriented similarly. So you're looking at the 25 milligram dose, we see that this is a working memory test. That working memory is much more impaired for vaporized cannabis compared to smoked. And it usually happens shortly after administration. And then oral cannabis, we see that it's a similar magnitude of impairment as we see for smoked cannabis. It's just it happens much later in the day. So the way we can start to make sense of these pharmacodynamic data is to look at the pharmacokinetics. And so here what you're seeing are whole blood THC levels on the left, and then whole blood 11-hydroxy THC levels on the right, which is the psychoactive metabolite of THC. So first looking at whole blood THC, we see that overall vaporizing resulted in greater delivery of THC. So this explains why people are feeling stronger effects. And so what we think is happening here is that when you smoke cannabis, some of the THC is being lost in the combustion process. And so vaporizing cannabis preserves more of the THC and ultimately delivers more drug to the person. You see that for oral ingestion, interestingly, there's very low levels of THC being detected. So even though we saw a similar magnitude of pharmacodynamic effects from oral cannabis ingestion, as we did with smoked, the THC levels are much lower. And again, looking at the whole blood 11-hydroxy level, so this is the psychoactive metabolite that's formed in the liver as a result of metabolizing THC. We see that it's a similar relationship for smoking and vaporizing, but we actually see higher levels for oral cannabis. So this is because oral cannabis undergoes first-pass metabolism. So this suggests that the 11-hydroxy metabolite is having more of an influence on the effects of edibles than perhaps it does for inhaled forms of the drug. So some of the implications of these studies we took away were that, again, overall, not surprising, the effects of cannabis increase as THC dose increases, but the effects are very different depending on the route of administration. Vaporized cannabis might produce stronger effects. This is a really important consideration for novice users in particular. And oral cannabis effects are delayed, but of a similar magnitude to smoked. And this has critical implications for dose titration, as well as the occurrence of adverse events. A very common scenario that can result in over-intoxication is someone takes an edible, they wait 45 minutes, they don't quite feel the effects, they take another one, and then both doses kind of converge at the same time and result in a stronger effect than the person was bargaining for. So moving on to some of our other studies we've done, so these are all looking at the influence of non-THC cannabis constituents. And the reason this is important is there's been recently theory popularized by Ethan Russo called the entourage effect. And so historically, most people thought that THC was the main driver of the effects of cannabis because it is the predominant psychoactive component. But this theory basically asserts that the effects of cannabis are not just driven by THC, but all of these minor cannabinoids and terpenes and other constituents are influencing the effects of cannabis, either through effects of their own or acting synergistically with THC. So probably the most common scenario or common example of this that people are familiar with is that it's often alleged that CBD can mitigate the negative effects of THC. So this is a very common belief held by not only cannabis users, but also you typically see this kind of propagated by the cannabis industry. And obviously understanding how these other constituents are influencing cannabis effects has critical implications for medical use. So as many of you probably know, dronabinol is a FDA-approved THC drug. It's basically prescribed for chemotherapy-induced nausea, but it's really rarely used in medicine. And the reason for that is it has a really narrow therapeutic window. So if one of these constituents could expand that therapeutic window and make THC more tolerable, that would obviously increase its utility for medical use. Or conversely, if there's a constituent that exacerbates the chances of an adverse event, that's also really important to know. So that's some of the things we sought to answer in these studies. So we're doing a series of studies looking at the interactions of between THC and different terpenes. So I'm going to show you data from a study we just completed that's looking at the interaction between limonene, which is one of the more common THC or cannabis terpenes, as well as THC. We chose limonene because there is some preclinical evidence that limonene has anxiolytic effects or anxiety reducing. And obviously one of the more common side effects of THC is it has anxiogenic or anxiety provoking effects. So we were interested in whether administering limonene in combination with THC could potentially reduce some of these anxiogenic effects of THC. So in this particular study, people came in 10 different times. They used this device here. They vaporized the drugs through the Mighty Medic. So we have a placebo, we have 2 limonene doses alone, 2 THC doses alone, and then these different combination conditions. So what I'm showing you here are peak subjective ratings for 2 measures that are indicative of anxiogenic effects. So the first is anxious or nervous, and the second one is paranoid. And these are, again, on 100-point visual analog scales. So here you see the y-axis is the overall rating. And then you see here, these are the different doses of limonene, and then above are the different doses of THC. So what I'm showing you right now here is limonene by itself at the 0 milligram conditions, as well as THC by itself. So as we would expect, limonene alone isn't really making people anxious or paranoid. That's what we would expect to happen. Also expectedly, we see that THC by itself is eliciting an anxious response. So it makes people feel anxious and paranoid at both the doses. Now, if you look at the combination conditions, we are seeing, especially at the 30 milligram dose, that we're actually seeing a dose-dependent reduction in these self-reported feelings of anxiety and paranoia. So for example, anxiety, you see that as more limonene is added to the drug, to the vaporizer, we're actually seeing that there is a reduction in reporting of anxiety and paranoia. So it's about a reduction of about 50% or so. But what was really interesting about this finding was that we obviously gave out a bunch of other subjective questions, and we don't see this effect for anything else. So this is just overall self-reported drug effect again. And you're seeing that the magnitude of drug effect is pretty much the same when THC is given, whether or not limonene is also present. So it seems like the anxiolytic effect of limonene was very specific, and it wasn't really necessarily influencing other effects of THC. We also recently completed a study looking at THC and CBD interactions. So in this study, people did 3 separate experimental sessions. They consumed a cannabis brownie in each session. So one was a placebo brownie, one was a THC containing brownie. So it had 20 milligrams of THC with no CBD. And then the last condition was 20 milligrams of THC with 640 milligrams of CBD. So what we see in this study is that this is, again, subjective ratings for do you feel a drug effect? And so interestingly, what we find is that when you give THC and CBD together, it actually results in more pronounced or stronger effects compared to the same dose of THC by itself. And this is interesting because CBD alone doesn't really elicit it isn't really intoxicating. It doesn't produce psychoactive effects. So if you gave, we didn't give CBD alone, unfortunately, in this study, but if we had, we would expect it to be more similar to placebo than in either of these other 2 conditions. This is also the same trend we saw for cognitive performance. So this is, again, our working memory test on the left. So lower scores indicate worse performance. And then this is a divided attention task where higher scores indicate worse performance. And so again, we're seeing that the combination of THC and CBD is resulting in more pronounced impairment on these measures compared to THC alone. And again, the reason this is happening can be explained by the pharmacokinetic data. So looking here on the left again is our THC in whole blood, and then the right is the 11-hydroxy metabolite. And so we're seeing that together THC and CBD result in greater concentrations of THC. So the 2 cannabinoids are inhibiting each other's metabolism and resulting in greater concentrations of THC circulating. And this results in obviously more pronounced pharmacodynamic effects. Another study we have going on that's kind of getting at non-THC constituents is a delta-8 study. So this is an ongoing study. We're looking at basically a head-to-head comparison of regular THC or delta-9 THC compared to delta-8 THC. And so in this study, people come in 10 separate times, 5 oral dosing conditions, 5 vaporized conditions, And so they get a placebo, the 3 different delta 8 doses, 10, 20, and 40 milligrams. And then they get a delta 9 dose of 20 milligrams, which is kind of our comparator condition. And again, we do this for both oral dosing and also for vaporized. So I'm just going to show you subjective ratings for field drug effect again. So these are peak ratings. And so starting off looking at oral dosing, we see that there's pretty nice dose orderly data within delta 8. So we see that self-reported drug effect is increasing as delta 8 increases. And we see, interestingly, that if you look at 20 milligrams delta 8 versus 20 milligrams delta 9, delta 8 appears to be much less potent. And so this is actually something that research on delta 8 hasn't really been done since the 70s, but those research studies back in the 70s also showed similar outcomes, that delta 8 has about half the potency of delta 9. But interestingly, if you increase the dose to 40 milligrams, you see that you're starting to approach the same level of effect as the delta 9 dose. So even though there is less potency for delta 8, you can overcome that by just taking a higher dose. The data for the vaporized conditions look less clean right now, and so you see that there's actually similar ratings of drug effect across all 3 delta 8 doses, and then we see higher ratings for delta 9. Most likely what's happening is there's some dose titration occurring. So we do have some puff topography data that we're going to look at, and that can help us to kind of pick this apart a little bit and understand what's going on. So some of the implications of this line of research is that we are understanding that some non-THC constituents, such as the terpene limonene, appear to mitigate the effects of THC, while other constituents, such as CBD, can, under some conditions, exacerbate the effects of THC. And in this case of CBD, this is likely due to pharmacokinetic interactions when they're both being given orally. But there's actually been some studies with THC and CBD for when they're both inhaled, and the evidence is a little bit more mixed as to whether there's an interaction there or not. We also know from our research that delta 8 seems to be less potent than delta 9, but again, this potency reduction can be overcome by just taking higher doses of delta 8. So our conclusion from this line of research, as most of our conclusions are in this field, is that we need more research. There's so many other non-THC constituents that we really haven't begun to scratch the surface to understand how they all impact the overall experience of cannabis and how they might influence the effects of THC specifically. Some other product features that we're starting to understand might influence the effects as well are the liquid vehicle or food matrix of oral products. And so as I talked about at the beginning, cannabis edibles are one of the most diverse product categories. So there's brownies, there's gummies, there's drinks, there's hard candies, and these all have different constituents. They have different food matrices. Some are high in fat, some are low in fat. So we really don't have a great understanding yet of how all these different matrices could impact the absorption or effects of these products. We did do a small pilot study looking at different oral solutions of CBD. So we basically gave people CBD 100 milligrams in a capsule, 100 milligrams in the form of Epidiolex, and 100 milligrams of CBD suspended in a cough syrup, kind of like a commercial cherry flavored cough syrup, like for medications. And overall, what we found in this study was that, again, holding the CBD dose constant, the absorption of CBD can differ pretty drastically depending on the formulation. So we see the highest absorption was occurring for Epidiolex, and then we see the next highest was for the capsule, and then much lower was the syrup. So Epidiolex was about a 2-fold difference from the capsule and about an 8-fold difference in absorption from the syrup. But again, same exact CBD dose. And so you can imagine if this were THC, this could also potentially result in differences in pharmacodynamic effects as well. Another kind of offshoot of that study was we had an additional condition where people came in and they fasted and took CBD under fasted conditions. So interestingly, if you look at this graph here, we see that people under fasted conditions absorbed much less CBD compared to those who had when they ate the low-fat breakfast. So that's not necessarily a product factor, it's more of a user factor, but again, I think it's important to illustrate how many different things there are that can influence the effects of these products. So just some quick implications for product features. So we know that oral formulation can influence bioavailability of cannabinoids. Other features of products like the vehicle used in vapes could also be important. We know that from nicotine research. No one's really done it yet for cannabis. We also know that there are some user factors that are important. So diet, as I showed, but also there are sex differences that are really important and can mediate PK and PD effects. And we really need more research in this area too, given the sheer diversity of products and formulations and the expanding use in new populations such as older adults. All right, so I'm going to switch gears here now and talk about our cannabis impairment research that we have going on. So again, just a refresher with cannabis impairment research and why that's important. Again, the incidence of driving under the influence of cannabis has been increasing, especially in states where cannabis legalization has occurred. And so there's a growing need to be able to objectively identify people who are impaired. Currently, there's two different primary methods that are being used by law enforcement to detect cannabis impairment at the roadside, and those are blood THC levels. So some states have adopted per se limits, meaning that a particular concentration of THC in the blood equals an automatic offense, similar to 0.08 resulting in a traffic offense for alcohol. And then other states are even more restrictive than that, and they have zero tolerance thresholds where any amount of THC or metabolites in the person's system could be considered an automatic offense. And then the other approach is effects-based laws, so things like field sobriety tests or DRE assessments. And so these are performance-based tests that if someone were to fail them, they could be charged with an offense for driving under the influence. And a lot of states will use some combination of the two of these, but some states will use one or the other. So one of our first questions we had in this line of research was just to try to understand whether these current methods are effective at all at identifying folks who are impaired. So getting into field sobriety tests, so the way that these work is essentially a person is asked to perform a series of tests. So here you're seeing a picture of the walk and turn test. There's also a test called the one leg stand, and then horizontal gaze nystagmus. And while the person is doing these series of tasks, the officer is looking for distinct behavioral indications or clues that they might be impaired. And the more clues that someone exhibits, the more likely it is that they're impaired. And importantly, all of these tests were validated for alcohol at common per se limits. So there's been studies that have basically, in a really controlled way, determined that at 0.08 BAC, that these tests reliably show that someone is impaired. They haven't necessarily been validated for cannabis, which is an important point. So these are data from a study we did a couple of years ago where we administered these tests and we gave people oral cannabis or vaporized cannabis in different experimental sessions. So to orient you to these graphs, the y-axis here shows the number of participants. So these are just count data, and then the number of clues is on the bottom axis. And so for the walk and turn test, you can have 8 possible clues or signs of impairment. And the main takeaway from this graph is that we did not find any differences across the experimental conditions. So in other words, people were showing the same rate of impairment clues at the high dosing conditions as they were in placebo, and this was consistent across both routes of administration. So this suggests and led us to conclude that these tests may not be necessarily sensitive to cannabis impairment. Again, the other approach that people are generally using to identify folks as impaired is blood THC concentrations. And so looking first at the oral cannabis conditions from that study. So here on the left, we see whole blood THC levels, and then here's an impairment test, and then subjective drug effect ratings. So a couple of important things to point out about oral cannabis is that, again, as I mentioned before, the blood THC levels are extremely low. So on average, even at the high 25 milligram dose, the mean concentration of THC isn't over 5 nanograms per ml, which is actually a per se limit used in some states. But despite those low levels, we are seeing people getting reliably impaired from the dose and also reporting pretty substantial drug effects. So if you were to judge someone as impaired based simply on their blood THC levels and they had ingested a cannabis edible, you may not necessarily judge them as impaired, even though they could be unfit to drive. For vaporized cannabis, there's very different relationships happening. So here again on the left, you see whole blood THC levels. And so unlike with oral ingestion, the THC concentrations in blood is very short-lived when you vaporize or smoke cannabis. So we see an immediate spike after inhalation, and then by an hour or two post-drug administration, it's pretty much back to baseline. But people stay impaired for well after that time. So they could still be impaired for 1 to 2 hours after vaporization or even longer, and they certainly would feel a drug effect. So again, this suggests that if you were to judge someone as impaired just based on their THC levels alone and say that you pulled them over an hour or two after smoking or vaporizing, they may not be considered impaired, even though they still are unfit to drive at that point. So beyond these two existing kind of methods that are already in place, there's many different approaches to detecting cannabis impairment that are under some stage of evaluation or investigation. So this is kind of the holy grail right now of cannabis research, is trying to identify a reliable and accurate impairment detection method. And people are kind of approaching this problem from many different ways. So there's novel behavioral tests that are being developed. There's non-THC biomarkers that people are trying to explore, eye tracking technology, THC breathalyzers, and there's limited research to validate many of these other approaches, and a lot of the research is kind of still ongoing to know whether any of them are going to be reliable. We have in our research looked at one of the novel behavioral tests called the Druid. So this is a test that's administered on an iPad, and it consists of 4 separate performance tests, and these different performance tests kind of tap into different behavioral domains. And these are integrated to produce a global impairment score. So in that same study I just showed you with the oral and vaporized dosing, we did actually see pretty good sensitivity of the Druid. So we see that for oral dosing and vaporized dosing, there was nice separation between the high dose condition and the lower dose, as well as placebo. And again, that was consistent across both routes of administration. Now, whether this is necessarily going to be effective for the roadside is, I think, still yet to be determined. And so we're doing more research to kind of further validate this tool. So in line with that, we're doing one of our next steps we're doing as far as the impairment research is to start to integrate simulated driving. And so we have a new project that is looking at oral cannabis and alcohol combinations, as well as vaporized cannabis and alcohol combinations. And a big part of that research is to try to understand whether the Druid is at all related to driving performance. So in these particular studies, we're giving people, it's a double dummy study, so they always get active or placebo cannabis and always get active or placebo alcohol. And so you see we have a couple THC doses alone, we have a couple alcohol doses alone, and then we have combination conditions. So as far as our driving simulator, we have a few different tasks that people do. So we have controlled driving tasks where people have to do either a car following test. So basically you have to maintain a constant distance behind a lead vehicle, which accelerates and decelerates periodically. So kind of replicating what your experience might be like driving on the highway or in traffic. And then we have a divided attention test where people have to essentially do 2 different things at once. They have to respond to stimuli that pop up in their screen while also trying to maintain their position in the lane. We also have integrated different crash avoidances throughout our drives. So people are driving along and they have to suddenly stop or react to an avoidance that might happen. So here's an example of she's driving through a neighborhood and then you see a dog walk out and she has to brake. And so we can measure things like braking reaction time and time to collision at the time of her stopping. And so some of our data coming out of that first study are really neat. So these are preliminary driving data. So far, we've had 9 people get through the study. And overall, we're seeing this is a global drive score. So it's essentially integrating performance on all of those different tasks that I showed you. And so we're seeing that overall, we've had nice dose orderliness across the THC doses and the alcohol doses alone. And we're seeing that the combination of cannabis with alcohol is resulting in additive impairment. And what's really interesting is that at 0.05 plus 25 milligrams THC, we're seeing a similar degree of impairment as 0.08, which is obviously the per se limit for alcohol. And these are just the same data, but showing the time course. So here on the left are the THC doses alone. These are the alcohol doses alone, so 0.05 and 0.08. And then these are the combination conditions. So again, showing really interesting additive effects for the combination of alcohol with cannabis. All right, so just an overall summary of everything that I've talked about today, and then I'll go ahead and we can get into some questions. So in our research, we find that route of administration, non-THC constituents, and product characteristics, as well as some user factors, all influence the effects of cannabis. But we really need a lot more research given the sheer diversity of products. It's already complicated in just what we've done, but it's going to be much more complicated as we continue to do more and more research. And we really need to have some novel approaches to identifying cannabis impairment. The current methods that we use, blood THC levels and field sobriety tests, simply aren't validated for cannabis. And so as cannabis legalization continues to expand, there needs to be more measures developed that are more reliable. And I think that human laboratory studies are really an ideal way to start to systematically research these topics and ultimately inform future regulatory actions for cannabis. So with that, I'll end. So I just want to thank all my collaborators, especially Ryan Bondre, my PI in my lab, my co-PI, also our many research and nursing staff, NIDA drug supply program for supplying our cannabis for our studies, as well as our study participants. And if anyone wants to see what studies we currently have going on, you can scan this QR code here. All right, thank you.
Let's see. I was thinking Jeff was going to give you the questions.
Yeah, I'm looking through them right now.
Oh, you can see the questions?
Yeah, I can see them.
Okay, well, I'll just let you field them if that's okay, Tory.
Sure. So John Reuter asks, can you tell us if these were done with a Schedule I license in your lab and the source of the tested products? So yeah, so we have a Schedule I license to do all of this stuff, and we typically get our drugs from, if it's cannabis, we get it from the NIDA drug supply program. That's really the only way that we've been able to successfully secure cannabis for research purposes at this time. We have a couple other studies where we've given THC, pure THC synthetically made, and those we've gotten the drug imported from a company in Germany for those studies. I don't know if you have any other specific questions about that. That's actually the only specific question I can see.
Let's see. Actually, you have it looks like 3 more, but John's may have been asked again. If in the little thing down below, if you see Q&A, do you have that tab at the bottom?
So I'm just looking at the webinar chat.
Okay, well, let me just read them to you, Tory.
Okay, sure.
The first one is, did you use a double placebo design in the THC limonene study?
A double placebo. So that is not a double dummy design. So the placebo in that study is distilled water, actually. So it's the Mighty Matic vaporizer, and there's a dosing pad. And so essentially the dosing pad is injected with either THC by itself, limonene by itself, or both of them, or distilled water, and that's what people vaporize.
Okay, and the next one is from David Gorlick, and it's how do current federal regulations of cannabis and cannabinoids hinder your work?
Well, I think I would say they hinder us quite a bit in that we can't study products that are at dispensaries. And so we can only get cannabis that is either from the NIDA drug supply program or other DEA approved cannabis grow sites. At this time, there really isn't other sites that are up and running and can supply cannabis research purposes. So I think in terms of the diversity of cannabis that we can study, we're pretty limited. And I think the other thing that is challenging is also all of our research requires FDA approval. by way of getting an IND application through FDA. And those can sometimes be very challenging to obtain, and oftentimes you need precedent for studying a particular drug. So even if you're studying a minor cannabinoid that people are using widely, oftentimes you have to kind of change your design or be very selective in what you could do, even though that it's widely available to consumers.
Okay, and another is, have you completed any studies on oral fluid, and what is your opinion on oral fluid as a better recent indicator of impairment versus blood?
Yeah, so oral fluid has a lot of the same issues as blood. Oftentimes what we see with oral fluid is that it's more a reflection of contamination of the oral cavity than it is circulating levels of THC. And so, for example, if you give someone a cannabis edible and a vape, the time course for oral fluid looks almost identical in our experience. And that's because it's either detecting the THC that's been contaminated in their mouth from vaporizing or from ingesting the cannabis brownie that we gave them. So I think it does have some benefits in that it's less susceptible to kind of circumventing drug testing. So you can have someone spit in a tube in front of you and there's no issues there, and they're not going to really be able to circumvent it as much as like a urine drug test perhaps. But I don't think it's necessarily any better at, or any more correlated with impairment than THC in blood.
And I have a question for you. I've been interested in the simulators, and I know they have simulators from something like an Xbox all the way up to the simulator they have at the University of Iowa. And
yeah.
I was just curious, what level of simulator and what kind are you using?
So ours is somewhere in between. I have a picture of it here, I think. Yeah, so here's our simulator. It's made by a company called STI Sim. They're based out of California. So it's kind of these 3 panel screens. So it kind of gives you, I think it's like a 270-degree view of the drive. It's certainly not as immersive as the Iowa simulator, I wouldn't think, but people do you can see they start to get immersed in it. So for example, if they're changing lanes on the highway, they might like look over their shoulder. And so it does trick your brain into thinking you're actually driving.
I think those are very cool.
Yeah, and one plug I'll just put out too, for anyone that's interested in driving simulation work, we recently wrote a protocol paper where we essentially shared the drives that we're using in this study. Because one thing I was finding as I was starting this research was that everyone's doing different stuff, and people don't necessarily want to share their drives with you if you ask them. So we, as a resource to other people and hopefully to promote some consistency across studies, we are sharing the exact drives that we are using. And so if anyone wants to or is interested in that, you can follow up with me.
Great. And we got one more question. Hopefully we can get it in here. What do you think about using the 11-hydroxy as an indicator of impairment in blood versus THC itself, since data show the first pass effect has a significant impact?
Yeah, I think it does have an impact, but I think the difference is that it's not necessarily the same across routes of administration. So it's not really going to be a silver bullet any more so than THC in blood. So yeah, I think that the conventional ways that we've tried to understand in terms of biomarkers for identifying impairment have kind of consistently failed. And yeah, so I don't think that the metabolites are necessarily any more predictive than THC.
Okay, and let's see. I believe, Tory, we may have one more question. Yes, does the vaped limonene have a perceptible flavor have you considered trying non-terpene flavors for comparison? And given that the THC metabolites are intoxicating, are there studies examining genotype or different CYP alleles and level of intoxication? I guess that's more in depth than a single question, but
Yeah, that's a loaded question. So it does. So the limonene does seem to have a perceptible taste. So we've struggled a bit with blinding in that study, also in the sense that the aerosol produced when you exhale limonene versus THC is different. And so what we've actually started to do is have people exhale into like a little smoke filter so that they can't actually see the aerosol. But there's so many different conditions in the study. There's a lot of limonene conditions. There's a lot of limonene with THC conditions that even if they taste the limonene, it doesn't necessarily tip them off to what condition they might be in at that moment. But yeah, that's certainly a challenge with blinding. As far as the other question, I think there is a lot to be done with looking at how genetic factors influence metabolism. In pretty much all of the studies we've ever done, we'll use the same population, for example, people that don't use very often and frequent users. And some people will tolerate the dose very well. They won't really report much of a drug effect at all. And then for the next person, same BMI, same height, weight, same gender, that person might be completely impaired and not coherent from the same dose. So I think that there is something to be said for genetic factors that can influence the effects.
well, Tony or Tory, I really, really appreciate you being with us today and giving us a very exciting talk. Sometimes we do get questions in a little later on, and when we do, we will send them your way. But again, I would enjoy, I very much enjoyed your talk, and thank you very much for being with us today.
All right, well, thank you again for the invitation. I appreciate it.
Bye-bye.